Hello, my name is Lichaa, coming to you with another video on a topic that I think is important in the interventional and the vascular world and coronary world, wire behavior and location. This is part of what is considered kind of the art of maneuvering the wire, but it could be taught in a systematic fashion. I'm going to try to categorize wire behavior into different categories to try to make it more teachable topic. The wire and the true lumen, whenever the wire meets the proximal cap and moves on in the trajectory of what the operator thinks is the architecture of the vessel, it could be either true luminal or sub-intimal, and we're going to analyze in the next few slides how we can differentiate the wire behavior in the true luminal space versus a sub-intimal space. The wire can also prolapse on the proximal cap, and the way it prolapses can be the tip can still be facing the proximal cap. And obviously, wire choices are very important in this case if the wire is having a hard time crossing. Or the wire can prolapse in a way that its body is actually facing the proximal cap and it's starting to form a loop. At this point, the operator can make a decision of going back to having the tip facing the proximal cap versus taking that loop into the sub-intimal space most of the time. Now, obviously, the other possibility is the wire kind of gets away from the trajectory of what the operator thinks is the architecture of the vessel, and that can indicate either that the wire is in a branch, collateral, or the wire is actually in the true vessel, which is very tortuous, and this portion is unknown to the operator, or literally extravascular, completely out of the vessel. We're kind of detailing the wire in the sub-intimal space if we have the luxury of having the reconstitution of the vessel, which is most of the time possible in the femoral popliteal space, and the wire reaches that area, usually under DSA, or in the coronary world, dynamic coronary roadmap. If the wire starts looping into that space, obviously the most likely location of the wire is in the sub-intimal space rather than true luminal position. When the wire makes a kind of a move to the lateral aspect of the vessel, there are fine little details about wire behavior that indicate if the wire is still in a collateral or if the wire is in the true vessel, which is tortuous. So you can see here that the way the wire behaving here, the movement, the lateral movements of the wire are very narrow. There are no major buckling here, just a small amount of movement. And if the operator thinks that the reconstitution of the vessel is lined up with the proximal cap, then of course this is a wire in a branch or a collateral. The alternative is that the wire is also behaving in a way where the lateral movements are pretty narrow. There are no major loops and buckling going on, but the operator thinks that the reconstitution of the vessel is in the lateral space. Then of course this would be a tortuous segment, and the wire is either true luminal or sub-intimal in the architecture of the vessel. Now, whenever the wire starts making very large loops at the distal aspect, or if it's buckling in its distal aspect or mid aspect with very large movements, lateral movements of the wire, then you're almost sure at this point that your wire has exited the architecture of the vessel. And that's usually not a major problem in the peripheral world or even in the coronary world, as long as one does not follow it with equipment or balloons or microcatheters. Now, what usually goes on in the real world is much more complex than that. Usually the wire forms a primary loop, and the operator keeps maneuvering or rotating the wire and forms a secondary loop. And finally, there are some very little hints of a third loop forming in the most distal aspect of the wire progression that indicates that the wire is going into the architecture of the vessel, and that's a tertiary loop. And most of the time, the operator takes that and keeps going if they think that this is the right trajectory of the vessel. So most of the time, the way we cross occlusions is in a very complex way. The most important teaching point in this on this topic is never to treat or to advance equipment on top of a wire without 100% confirmation of wire location. You absolutely need to know that, which is a major safety point in these procedures. And that's about it on this, and I hope you found this interesting. Thank you.